Good afternoon, ladies and gentlemen, and welcome to the VTE from Welsh Perspective session of this National Thrombosis Week 2024 session. I hope you're making the most of this impressive conference. Awarded 17 CPD points, the National Thrombosis 24 platform provides 21 hours of live sessions until Thursday, 9th of May. And then access to accredited catch-up recordings hosted within the platform until May 31st. It's really worth visiting the exhibition hall for resources, networking and professional bodies and further information and opportunities. And we would like to thank our supporters and sponsors who have helped make National Thrombosis Week 24 possible. My name is Andrea Croft. I'm a lead advanced nurse practitioner in anticoagulation, working in the Princess of Wales Hospital in Bridgend. And I want to start by giving you an overview of what's been happening in Wales over, well, recently and past years. So thank you, Joe. So first, Wales, the nation. So there are 3 million people residing in Wales. We have our own language. It's the oldest language in Britain. There are more sheep in Wales than people, approximately 10 million. And our economy includes agriculture, industries such as manufacturing, steel at the moment, aerospace, and the service sector such as tourism. The geography of the country is varied with mountain, sea and pasture, so there's something for everybody. Rugby is the national sport, sometimes maybe football or even cricket. And we have a unified approach to reduce the number of hospital-acquired thromboses in our nation. So Wales is made up of 7 health boards and Velindre Cancer Care Centre, which sits in within Cardiff and Vale. So we've got Hywel Dda, Swansea Bay University Health Board, Cwmtaf Morgannwg, Betsy Cadwaladr, Powys, and Iron Bevan, and Cardiff and Vale, which also includes Velindre Cancer Care Centre. So just to give you some background, in 2012, approximately 900 people in Wales were reported as dying from venous thromboembolism-related causes. Not all of these deaths were avoidable, but many may have been. And many survivors of deep vein thrombosis suffer long-term psychological and physical effects. Most cases of VTE occur during or following a hospital admission. VTE can have long-term effects on survivors. Up to 40% of patients develop a chronic condition called post-thrombotic syndrome. And research completed in Wales identified psychological complications with some symptoms suggestive of post-traumatic stress disorder. And you may have seen that Professor Paul Bennett has been given some excellent sessions during this conference on the psychological complications that they have studied here. Most cases of VTE occur following a stay in hospital, and these are known as hospital-acquired thrombosis, or HAT. And most of these cases can be prevented with simple preventative measures, early risk assessment, and appropriate thromboprophylaxis. In 2012, following a one-day inquiry held by the Health and Social Care Committee, the Welsh Government issued recommendations to NHS Wales to encourage improvement. These recommendations were making reporting of HAT a Tier 1 priority. Our Tier 1 priority is the equivalent of the sequin payment in England. Mandate risk assessment and thromboprophylaxis treatment. Develop standardised HAT rate. Undertake root cause analysis of all potential HATs. And increase clinician and public awareness. Following the 2012 inquiry, this group, the All Wales HAT Steering Group, was set up to implement the Tier 1 recommendations made by Welsh Government. The group included a multidisciplinary membership from all 7 health boards and Velindre Cancer Care Centre in Wales. And it also includes clinical trustees and patient representation from the renowned thrombosis charity, Thrombosis UK. The steering group agreed the definitions for HAT and a methodology for collecting potential HAT incidents. Importantly, they recommended changing the reporting measure from a hat rate to hat incidence, and this provided an emphasis to potential harm to individual patients and proved more beneficial in engaging with NHS staff. So relating an incident to a person rather than looking at a figure on a page, we found was far more beneficial. The group has also developed and agreed a risk assessment process for working in collaboration with the All Wales Medication Chart Group. This resulted in a change to the first prescribed medication box in the All Wales Inpatient Medication Administration Chart, and it made it easier to ascertain whether a patient had been risk assessed and whether the correct form of prophylaxis had been prescribed. Not all VTEs can be avoided, and the group wanted to create a measurement system that could identify those potential cases that could have been avoided if the correct steps were followed. Therefore, a screening tool was included in the reporting mechanism. Potentially avoidable hats were identified by asking two simple questions. Was a VTE risk assessment carried out? Was the appropriate form of prophylaxis given? If the answer to either question was no, then the case needed to be investigated further. In 2015, the method of recognising potential hats was linked to Welsh Government's Tier 1 reporting mechanism, where health boards were required to report the number of potential hats identified, which was monthly, the number of hats that were potentially avoidable, quarterly, and lessons learned from subsequent root cause analysis. The greatest improvements were made in the promotion of reporting, reviewing, and reacting to potential hat incidents. Every health board in Wales collected and reported potential hat incidents to Welsh Government. The report included the number of incidents where root cause analysis had been carried out and what lessons had been learnt. And we met as an All Wales hat steering group regularly to discuss which lessons had been learned. We looked at incidents, we looked at good practice, we looked at areas where things were perhaps not going so as well as they could, and we all shared and helped each other to improve the situation across Wales and provide a better service and better patient care. Analysis has shown that this has had an effect on increasing the number of assessments performed in a virtual circle, so that should result in the number of incidents decreasing. And you'll see now on these graphs that that is exactly what we've done. So by reporting, talking to each other, sharing good practice, and really importantly, putting our VTE risk assessment tool on the front of our medication chart in 2016, you can see at the top chart with the blue line showing a decrease in potentially preventable hats across Wales, and that was between 2016 and 2021. In comparison, you could see the lower graph, which is the uptake of VTE risk assessment, and again, that step is in 2016. So the figures have gone from around 50 to 60% until we added in the new VTE risk assessment on the medication chart, and that figure then has gone up to around 80%. The next slide, please. You can also see that on these two slides, the top slide showing the green line decreasing from around 2015-16, and the red and blue lines increasing, that being the uptake of risk assessment and reassessment, and the green line being the number of hats decreasing. And the blue line at the bottom also shows in 2016, when the medication chart VTE risk assessment was added, there was a distinctive step and increase in the number of risk assessments which were undertaken. Thank you. So as a result of the changes, there was a steep increase in terms of the uptake of VTE risk assessment, as just shown on those graphs, due to the change in the medication administration chart, and demonstrated improvement in patient safety with an increase in the number of potentially preventable hats since the beginning of the Welsh Assembly Government hat root cause analysis project. Thank you. So we learned from that collaborative working between governments and clinicians can result in a sustainable nationwide improvement. Some organisations have identified hats that were potentially preventable and pinpointed areas of learning so that future delivery can be improved. To ensure that all organisations can benefit from this learning and to prevent similar incidents going forward, Details of individual health boards' lessons learned and corrective actions are provided in text and disseminated in our annual report delivered to all HAT leads. And the submission of incident reports has generated discussion amongst consultants, resulting in improvements in prescribing and documentation. So in October 2021, the NHS delivery framework for 21-22 no longer included the following measure: the number of potentially preventable hospital-acquired thrombosis. This resulted in the removal of our Tier 1 target for Welsh Government. As a consequence, the loss of reporting the number of potentially preventable hospital-acquired thrombosis as a Tier 1 priority, and the relationship between the steering group and Welsh Government has been considered a setback. Wales does not have the same financial initiatives as England had at the time with sequin payment, and the Wales HAT steering group existence and all the good work we had done was in jeopardy. In 2021, at the same time that the Tier 1 priority was being removed, Welsh Risk Pool, Welsh Risk Pool is a part of the Shared Service Partnership for Legal and Risk Services, and it provides a means by which all trusts and health authorities in Wales are able to indemnify against risk. The role of Welsh Risk Pool is to have an integrated approach towards risk assessment, claims management, reimbursement, and learning to improve. The team worked with NHS colleagues across Wales to promote and facilitate opportunities to learn, support the development and implementation of improvements, and to enhance patient safety and outcomes. So when they carried out this national review of prevention, recognition, and the management of VTE in NHS Wales, with the aim of improving patient safety, their draft report identified a number of recommendations in which organisations were committed to address. The 5 recommendations, which were written or devised along with the All Wales HAT steering group, included all clinical staff to undertake All Wales training, both in relation to recognition of patients presenting with the VTE and the prevention of hospital-acquired thrombosis. And the current uptake for the completion of this was set at 50%. We're currently awaiting review, and hopefully in June a meeting will take place where we'll start to review where we are with these figures. In 2023, in the spring, a fully interactive teaching and education tool was placed onto ESR, which is the electronic staff record, which allowed staff to go into classroom-based training to undertake e-learning and monitor their own compliance. The uptake of this, again, we're awaiting review of. All patients were to receive a documented VTE risk assessment using the Department of Health risk assessment tool or similar to assess each patient within 14 hours of admission or up to the time of the first consultant review. Again, this work is all ongoing, but we're awaiting to do a national review of it, which will hopefully come sometime after June. An All Wales checklist for the investigation of HAT is developed in order to maintain a uniform investigative approach across NHS Wales, and it is proposed that VTE risk assessment compliance data and HAT data will be reported locally each month to Clinical Governance and Welsh Risk Pool, and this then will put us back in alliance with Welsh Government. Welsh Risk Pool were made aware of the work plan of the All Wales HAT steering group, and both groups are looking to work in partnership to align goals and improve outcomes. Those outcomes are to improve patient safety, reduce mortality from VTE, increase the uptake of a full thromboprophylaxis risk assessment, to improve thromboprophylaxis education in all Welsh health boards, and reduce the number of claims associated with HAT and VTE. So the next steps, governance arrangements are being reviewed to ensure that HAT and thrombosis is being reported within patient safety and quality committees. We're working collaboratively with the All Wales HAT steering group in association with Welsh Risk Pool, and we can push for our re-affiliation to Welsh Government. Welsh Risk Pool are working towards a standardised approach for Wales and leading on a programme of work involving a scoping review So use of patient information leaflets, VTE risk assessment forms in use, root cause analysis processes relating to potential cases of HAT, local reporting processes for HAT data, VTE e-learning module compliance, and local education and promotion. The steering group will support the Welsh Risk Pool work plan and continue to drive improvements for VTE within their current ongoing work plan. The Wales HAT Steering Group and Welsh Risk Pool will work collaboratively to drive improvements to reduce the risk of patients admitted to Welsh hospitals developing potential life-threatening VTEs. Welsh Risk Pool are setting up a multi-professional VTE board, and there is a need to develop a whole system approach to VTE and include members of the All Wales HAT Steering Group, GPs, emergency medicine, clinicians. This will ensure there is a wider group to ensure and identify areas of concern involving incidents involving patients, including the development of VTE due to HAT, misdiagnosis, or medication mismanagement. Diolch yn fawr. Thank you very much. I think ideally what we should perhaps do is if anybody has any questions after the next sessions, if we have time, we can take perhaps a couple of questions at the end of each session. And then at the end of the whole session, we can look and see if we have time to do any extra questions. I think that would be the best way to go. So if you have any questions, please send them in and we'll pick them up and hopefully go through them at some point. Okay, so next, I would like to welcome Tehmina Riaz, who's a senior specialty doctor in the Department of Obstetrics and Gynaecology at the Princess of Wales Hospital in Bridgend. And Tehmina is going to present on VTE guidelines and their implementation in obstetrics and gynaecology, a local success story. Thank you, Tehmina.
Tehmina, I think you need to unmute. And can I just ask, do you want me to share your slides? Right, okay, you will need to unmute.
Am I unmuted now?
Thank you, yes.
Thank you. And yes, I would be very grateful if the slides could be shown. Thank you very much. Thank you for that introduction, and thank you for that lovely presentation, which leads on to our local story. I will go through, thank you, next slide, please. The all-Wales strategy and that you have already mentioned, some pregnancy-related guidelines and risk assessments, about our education and training of staff and patients, and also an overview of the protocols that we introduced in obstetrics and gynecology, and least but not the last, how we measure our success by audit and feedback, and some take-home messages in the end. Thank you. So as pointed out by my previous speaker, we have these guidelines for us in the health board, the All Wales Thromboprofile Access Policy, which came into being and was published basically in January 2020. And next slide, please. The important thing for us in Obs and Gynae is that we have a system of information dissemination, which is called WISDOM. This is unique to Wales, and WISDOM stands for Wales Information System for the dissemination of Obs Gynae and midwifery material. And as you can see, this can be accessed from anywhere. You don't need a hospital intranet. You can access this through Google if you write WISDOM Wales. And in one area, you get all the guidelines of all the 7 different health boards. Thank you very much. Next slide, please. So I'll go on to training, and I'm sorry that my slides have not been animated properly. So what training is available for us? As mentioned, we have the ESR training package. This is the same package that England has provided as part of ELFH module, and it is not mandatory for all staff, but hopefully it should be mandatory soon. At induction of all new staff, and I mean all new staff, which is medical, midwifery, and nursing, we introduce the topic, and we have mandatory face-to-face training for VTE prevention and management. We inform them of the links and pathways, how to access the guidelines, which include for us the RCOG guidelines, and the recommendations from the latest Embrace UK reports, which is very essential, because as you all may recognize that the RCOG guidelines are about 10 years old and are in the process of being revamped. The important thing that I would like to mention here is that the link person for all these new people who are coming into your department is the most important thing. We have a few midwifery VTE champions, some nursing midwifery champions who I go through with every 6 months or so with what has changed, what is needed to be revamped, and what needs to be reiterated. And that we are available via email, telephone. We have a non-judgmental approach. We are all approachable, and we hope that we are good communicators. And this helps eliminate a lot of the queries that remain unanswered for the mostly junior staff who have the task of assessing every new patient who comes in to the hospital and pregnancy patients. Thank you. As I mentioned about wisdom, and we do have 7 health boards, and they all have different guidelines in the sense, but the format is different. The content is nearly all the same. The risk assessment for our patients, I think the most important thing for us is that assessment happens before pregnancy. And we are very lucky that we have clinicians who do regular pre-pregnancy assessment clinics. And all our women who are contemplating a pregnancy and are on a DOAC will be referred to this clinic. Those who have had previous VTEs or have higher hypercoagulable states will be referred to this clinic, so that there is a pathway and plan for them as soon as the pregnancy test is positive, that we arrange them to go on to low molecular weight heparin. Also, this clinic makes them aware of their high risk factors, which unfortunately sometimes women are not aware of, and measures to minimize the risk, which I think is the most important part and difficult part for us to deal with. We were lacking in early pregnancy assessment of these women, and we have introduced in A&E VTE risk assessment forms. They are the same ones that the hospital has, but we have put them in bundles where the gynae forms are, so that they are aware that these need to be stapled with the admission forms. In the pregnancy with the midwife, there is a risk assessment form, and all patients who score more than 1 or equal to 1 will get the RCOG patient information leaflet, which informs them about reducing the risk of VTE in pregnancy. And we even have a pathway for those women who are low risk midwifery-led care, but they are still scoring 2. And we have a pathway for the prescription of low molecular weight heparin for 10 days, and they can go and deliver at home or in the birth center, but they will still receive this. The antenatal visits, we have introduced a new pathway in which at each visit, the VTE score is rechecked, or we try to recheck it if symptoms have changed or some clinical parameters have changed. And we have introduced reveighing at 28 weeks, and we were already reveighing at 36 weeks. At any antenatal admission, we do daily checks, and we remind our colleagues when they're doing the rounds in the morning to perform this check. And before they leave the labor ward after delivery, we are very strict about filling in the postnatal form, and that they cannot leave labor ward or theatre without the VTE prophylaxis being prescribed. In gynecology as well, as most other units, we were a bit lacking in our pathways, and we felt that there was a big need, and a lot has been done by the HAD steering group. The health board risk assessment forms have been revamped and are available at all sites. The All Wales inpatient medication administration record, and also there is a daily medical board round check and daily nursing assessment check list where it is recorded if they are having it. And also I might mention the pharmacy colleagues. They are so good at reminding us and also checking with us if the dose is correct, and reminding us basically if it needs to be done. And if we have not prescribed it, what is the reason for not prescribing it? Elective surgery was a bit better. We had a pre-operate assessment checklist, which again has been revamped. And on the day of the operation, the surgeon completes the checklist, and before leaving theatre, prophylaxis is prescribed by the surgeon with the time of administration and the duration that is required. Again, on the ward, pharmacy checks are done, the All Wales medication record, and daily VTE assessment by the nursing staff. There are complex patients, and therefore we have developed a perioperative anticoagulation and antiplatelet guidance for elective surgery. It is a multidisciplinary team involvement at the pre-op assessment level, and recommendations are made for the pre-op and post-op care of these women on a specific form, which is circulated and communicated to the patient, the surgeon, and the waiting list coordinators. This has helped reduce a lot of stress for everybody concerned, and hopefully will reduce further the incidence of surgical HAD in gynecology. Thank you. So then we come to how do we measure success, and what are the metrics? Which metrics do we use? There are many metrics to use, and I have put forward the audit, which we do regularly. Thank you. These are done 2 yearly consecutively, and the last audit, the antenatal booking audit, we achieved 100% standard. The antenatal admission audit, we didn't put 100% over here, we put 95%, and it was achieved. We have done 2 postnatal audits because the first audit was lacking in showing any progress, and we still didn't achieve the postnatal one, but we did manage to have a 50% improvement from the previous audit. So still work going ahead. Thank you so much to all the midwives and the doctors who deliver these women and had to fill these forms and the correct prescription of the low molecular weight heparin. Gynecology, we did 1 audit, and surprisingly, we did manage to achieve all the standards that were required. Just to say that there are no standards as such when we did this audit, but hopefully there will come standards for gynecology. RC of all VTE in pregnancy is being done by the hospital health committee, and I'm happy to report that our incidence of VTE in pregnancy, since 2012, I have maintained a database of all the VTEs that occur in Princess of Wales Hospital, and within 1 year of delivery. There is a caveat to it. If I'm not informed and if I don't come across the patient, basically I wouldn't know about it. But the incidence is much lower than that, which is for the whole of UK, and our incidence of gynecology associated HATs is also much lower than those predicted for all the other surgical specialties. Thank you. as I have said. Thank you. Next slide. So feedback. So we do regularly, ask for feedback from our colleagues and users of the guidelines. The comments from the staff were welcomed, and as is universally known, and from the last Embrace report as well, that risk assessment forms are very difficult for staff to fill in, understand, and it was felt by a few that risk assessment form was not user-friendly, and so we did change the risk assessment pregnancy form in 2024, and we have new forms now. What is lacking was feedback from the patients, which is the next project that we have, and hopefully we will be able to get some feedback from our patients as well. So my take-home message is that communication is the key to success. Multidisciplinary team working with the staff who are on the shop floor is very, very important in order to make guidelines implementation successful. Appreciate the input of all the various disciplines, which include our anticoagulation team, the consultants in the anticoagulation team in both Swansea and Princess of Wales Hospital, our pharmacy colleagues, the nurses, the midwives, and the doctors who look after these patients. And cooperation and determination of a few individuals in the department is always very essential to keep the things flowing. Change of people sometimes stops the progress of previous work that is being done. And last but not the least, listen to the users of the guideline. Thank you very much.
Oh, thank you, Tehmina. That was absolutely brilliant. Lovely to hear the work that you've been doing. And I can say you're a real star when it comes to this work, and have dedicated a lot of your time to it over a lot of years. So thank you very much for that. Do we have any questions for Tehmina, please? I can't see any. There's nothing coming through, but if anybody has any questions, we do have a minute or two. No, I don't think so. Right, well, thank you very much, Tehmina. That was brilliant. I look forward to meeting up with you soon. And now I'm going to move on to our next speaker, who is Dr. Rhys Morris. Rhys is based in University Health Board in Cardiff, and he's a medical scientist, I believe, involved with carrying out some work regarding the standards of scanning and reporting of DVT and PE. So I hope you can elaborate on that, please, Rhys, because I don't think I've given people enough information. So over to you. Thank you very much.
Thank you. I'll see if I can share my screen properly. Okay, I hope you can see that.
Yes.
So what I thought I'd do today is give a slightly different perspective, because when we're talking about preventing DVT and investigating HATs, we, I think, assume that the diagnosis that gives us our DVT rates is going to be correct. My background is both in prevention and diagnosis, so I thought I'd give a little bit of insight into the kind of questions we're asking ourselves in Wales currently about diagnosis and how we can move things on. I can move my slide. There we go. So the context for Cardiff and Vale. We have two main hospital sites, University Hospital Wales and University Hospital Llandoch. In the University Hospital Wales, we have been doing DVT scans since 1983, believe it or not, within the Department of Medical Physics and Clinical Engineering. So it's been a clinical scientist-led service for all that time. In University Hospital Llandoch, DVT scans are provided by the sonographers, who are radiographers, part of the radiology department, and quite separately. It's over a decade now, I can't remember the exact date. In University Hospital Wales, we have, with our haematology colleagues, developed a nurse-led DVT clinic that is co-located with the vascular ultrasound service and was led for a very long time by Rhys, our triple nurse specialist. And that provided an integrated route for patients for direct referrals from GPs into the DVT clinic, where they'd be assessed, have their scan, and be treated all in one place. And it's been a very successful model for us. But Marilyn has had to move on, regretfully, so we've had to look at making a few changes recently. So within Cardiff and Vale, we perform about 1,500 DVT scans a year at UHW. About 75% are negative. I don't think that's unusual for a service that gets direct referral from GPs. And about 75% are outpatient, the rest are inpatient referrals. What is interesting, though, is when we did a review a few years ago, about half the DVTs we diagnosed were below knee and a half above. We carried out a recent audit, and it seems now that the proportion above knee is proportion below knee, there's a mistake on that graph, is reducing. So we need to find out what the cause of that is, whether that's some change in the population or whether that's to do with the way we're scanning. So as Andrea mentioned, we tried to take an all Wales approach to VTE prevention, and the Welsh Risk Pool have asked all the centres to implement risk assessments and HAT investigations, which we're doing anyway. But the problem since Marilyn's moved on in Cardiff is she was voluntarily doing the HAT investigations, looking after risk assessments for the health board. There is no formal role to do that. So we're now without a resource. So we're having to look at ways that we can meet the Welsh Risk Pool requirements that are less labour intensive. Marilyn will be required to look through very many reports to find likely cases of HATs. We simply don't have the resource to do that currently. So could we, from our scans, produce an automated method of extracting the positive and negatives that didn't require somebody to sift through them to make sure that they were not false positives or negatives? So what I did was, in Wales, we have Welsh Clinical Portal, which allows us access to scans from all over Wales. So I collected from a couple of weeks ago some examples of reports for no DVT in a left leg. And this is the report from Cardiff and Vale. Now, this is quite a lengthy report for what's essentially saying there's no DVT, and it includes reference to all the things that have been scanned. The way our scan reports used to look a few years ago was like this, a simple sentence. So what's changed? What's changed is we appointed 3 staff from Bristol a couple of years ago, and the top report is how they were trained to do it, and the bottom report is how Cardiff was doing it. Well, which is better? And that's something we don't know. We don't get feedback from clinicians to say they like the long report, they like the short report. But clearly, it would be strange if we had 2 completely different ways of saying exactly the same thing. In Llandoch, our other hospital in Cardiff and Vale, this was the report. Now, you'll note in the UHW ones, one says no evidence of DVT. This one says no DVT was apparent. So you can see if we're training some algorithm to pick out whether that's negative or positive, we've got to consider some different wordings there. Other health boards in Wales couldn't have, and however, put a negative for VTE at the end of their reports. The reports themselves are quite different. I haven't heard this term sonovenogram before. I think that's either a very old or a very new description for Doppler ultrasound. And then Swansea Bay have a very short report that says no evidence of DVT, and Velindre say negative for VTE. So there is no consistency in the form of the report from Wales. Now, does that matter? Well, of course, it doesn't matter if the clinician who sees that understands the meaning. But if we're trying to sift through these automatically on an all Wales basis at some point, it will cause us complications. Then if we look at CTPA reports, now these are all done by radiology departments. Well, they're all free text pretty much. There doesn't seem to be any real consistency in structure. One here has put a code, no VTE, which will be helpful, but others don't. So when we're looking for incidents of automatic reporting of incidents of VTE, whether DVT or PE, we have a challenge. Even AI will struggle with picking out all the positives and negatives. And the reason I got interested in this is because we've had a couple of cases where somebody with not much confidence has written a report that says normal phasic flow found in femoral popliteal veins but cannot exclude DVT. And at least twice now, a clinician has interpreted that as being a positive and has anticoagulated them, when in fact the intention was that was a negative report. So could we standardize them? Is there any point? Well, if we're going to have an algorithm to pick out positive and negatives automatically, then we need some coding at least in those reports, or at least some standard phraseology. But how can we force individuals to do that? It's not possible in the current system to compel that for people reporting radiology scans. And what we haven't had yet is feedback from the clinicians. Do they value a lengthy report that lists all the veins where there are no spots? Or is it better just to say no DVT? Which brings us on to a slightly different problem, which is we assume the DVT scans are correct. We know that ultrasound scans for DVT, duplex ultrasound, has good sensitivity and good specificity. However, those validations were done against venograms and fibrinogen scanning many, many years ago. And the equipment they were using then to scan was nowhere near what we're using today. So we can't be sure, really, now that ultrasound is a gold standard, how good our scans are. The professions in the UK that perform ultrasound scans for DVT prevention are not the same. They can be clinical vascular scientists who are part of the Society for Vascular Technologists. They can be clinical scientists, or both. They can be sonographers. They will have different training. They will have different standards, different recommendations. We're increasingly seeing scans, rapid scans being performed in emergency units, in intensive care. Those scans may have, the people performing those scans may have very limited training, if any. So are they ruling out DVT, or are they actually trying to diagnose? So certainly in our hospital, those images aren't saved. There's no way to review them for anybody else to check whether they're right or not. And certainly as a service that looks after all the scanners in the airport, I can tell you that some of the vascular ultrasound systems being used out there are not very good, and some are very well set up. We do have some guidelines. This is from the SVT, and it's quite extensive, and I'm not going to read it all out. But what I would point out is that there's a lot of scope for individual practice in there. There's lots of the legs may be tilted downwards. Should be used. It says how you should start the examination, but it says you can assess spontaneous slow respiratory modulation augmentation. There is a lot of scope in there for doing your own thing. And this can cause problems. We, for instance, in UHW would always scan a patient's calf, and we'd always scan them with their calves dependent to enlarge the veins. Many centres do not. They perform the scan supine. It is, in my view, very hard to see the calf vessels when patients are lying supine, particularly if they've got any anatomical variations. So the SVT guidelines say that scanning calf veins is controversial. It isn't controversial if you know what you're doing and you're well trained and experienced, but unfortunately there are people trying to do it who aren't as well trained and perhaps don't have the backing or experience to make the diagnosis well. So why is this a problem? Well, if we're all doing different things, are we all producing the same DVT rates? One of the reasons why our below-knee DVT rate may be changing in Cardiff is nothing to do with the patients. It may simply be we're not agreeing where below-knee starts. Is it in the mid-popliteal or the distal popliteal or the proximal popliteal? Cardiff always used to use manual compression of the legs with colour flow. SVT promotes pro-compression without colour flow, but allows for colour flow. Different people prefer different options. In Cardiff, we started to treat where there is clotted saphenofemoral junctions. Not everybody reports that. A number of years ago, we had a locum trained in London who found 2 anterior tibial vein thromboses in one morning in our department, which was strange as we'd only ever seen one before in the previous 30 years. When we reviewed them, there was nothing there. I rescanned them myself. So a train, and unfortunately those patients were anticoagulated. So training standards are different. Not everybody is equally competent, unfortunately. So there are lots of variations in the way we scan, and that can be a large part of the difference in the DVT rates between centres. And it's something we ignore. It may be nothing to do with a prophylactic review, maybe nothing to do with risk assessments. It may simply be that some places scan in one way and some places another. And when I tried to work out why she diagnosed as anterior tibial vein DVTs, and I look back on some work we've done with another London centre, it was the definition of a DVT, that in Cardiff, the rule was, if you see evidence of DVT, it's a DVT. But elsewhere, people think, if you can't see flow, or the vein isn't compressible, it's a DVT. So that is a precautionary approach, but might encourage inappropriate anticoagulation, whereas the Cardiff approach maybe could miss things if we weren't properly trained. So all I wanted to do today really was to emphasize that diagnosis is not simple. It's very user dependent. It's very dependent on properly trained and well experienced staff. And as we're moving towards point of care testing, quick scans, we need to be very careful not to place too much emphasis on results that may not stand up to scrutiny if there isn't a very good underlying training there. And in Wales, what I would like to see is at least set some basic standards for what we expect reports to look like, what we expect scans to look like, so that all patients are treated equally and have the same standard of care. Thank you.
Oh, thank you, Rhys, for that really interesting talk. It's a bit of a minefield, isn't it? Every time we delve into anything to do with anticoagulation, there's just so many facets, and this is no different. Yeah, Gillian Kerr just said to everybody, very thought-provoking. It is, Gillian, because it's kind of opened up a can of worms that you see different reports from different radiologists and different patients that you deal with, but I guess we don't always think about how, well, I suppose the one terminology is where it doesn't distinguish whether there is or whether there isn't. And the amount of times you hear that phrase, err on the side of caution, and a patient will be anticoagulated because they've not said with any certainty that there is or there isn't a clot there. So Eleanor said we perform image QA and peer review are standard in our vascular testing department. Is your role as clinical scientist doing the scans, is that unusual, Rhys? Because you seem to
No.
be, there doesn't seem to be many of you about.
In the old days, we were unusual, but now that vascular science, which is part of the SVT route, is clinical scientists as well, increasingly in the future, what are now clinical vascular scientists are also clinical scientists, but in many places it remains with sonographers.
Right.
And in Wales, the practice varies from site to site.
So do you think there is, I mean, certainly in Wales, we've been able to do some things where we've got a standardized approach, certainly around hospital-acquired thrombosis. I mean, it's never easy and it takes time, but do you think this is something where we could get a standard approach, maybe across Wales or the United Kingdom, bearing in mind that, you know, we are made up of 4 different nations and things are quite different in each country?
It would be good if we had simpler guidelines, but I do sympathise with the SVT and other groups, because if you get 12 people around the table, they'll have 12 different opinions, and you end up with guidelines that have a lot of wriggle room, which is fine if you've got lots of experienced staff who know what they're doing. But if you've got people who only ever doing 1 or 2 DVT scans a week, it can cause problems in quality. So what I would like in Wales is at least to set a minimum standard that we would expect people to adhere to, and to provide peer support, that we could do peer reviews of each other's centres to make sure that we're all following best practice and learn from each other. It's done in other modalities. It would be something good to do in Wales for diagnosis of DVT and PE for that matter.
Yeah. Okay, well, just a couple of questions then. So Sue Bacon's asking how to get it automated. All reports are coded, so the business intelligence should be able to send a list of positive ultrasound and CTPA reports that have also had an inpatient stay within 90 days. That's how we get the data in Bristol. Well, we do get that data the same here, Sue, but I think the point here is that it's the disparity with regard to the reporting. I mean, I've certainly looked at a patient who's a suspected HAT and found that what's written on the report is that the patient's mother had a DVT. And that is why the patient has been linked in with that 90 days. They've not actually had a clot. It's because the mother had a DVT. And I think from what you're saying, if we can refine it so that we're only picking up more accurate information, we'll get rid of a lot of the reports.
Yeah, we can do coding, but we're relying on people doing the scans to use the coding. And I think it's easy for us in Cardiff just to set up a database of positive DVTs, but that's not something we can implement in other sites.
Yeah. Eleanor, just one last quick one before we move on. Eleanor Walker. Yes, Eleanor, we discussed sending a survey to the physicians when the HAT steering group met last week, and Rhys spoke to the group then. And that was one of the things that came out of our meeting, that we should put a questionnaire out to our physicians to find out exactly what it is that they want. So yeah, that's our kind of next step to see where we go with this. But it's a fascinating subject and it's so broad. So thank you for coming along and sharing it with us, and hopefully well, you haven't heard the last of us yet, Rhys, and we'll move this forward and hopefully get some kind of a resolve in time. But thank you very much. I'm very grateful. Okay, so our next speaker then, I'm delighted to welcome Sue Wooler, who's lead pharmacist for anticoagulation and clinical services at the Royal Glamorgan Hospital, South Wales. And Sue is going to talk through her work on ensuring and enhancing patient and carer experience. So over to you. Thank you, Sue.
Okay. Can everybody hear me?
Yes.
Okay, yeah. Okay, so thanks, Andrew, for that introduction. And I've been asked to talk to you today about the benefits to patient care and experience, and most importantly, safety, of having a multidisciplinary approach to managing the diagnosis and treatment of VTE. And whilst I'm delivering the presentation, I do so on behalf of the excellent team behind this service. So where does the patient journey start? Generally at the GP surgery, and usually, although some patients come via A&E. In a recent snapshot of 1 month's activity, there were 135 query VTEs, 31 via ED and 104 via the GP surgery. Patients are directed to our ambulatory emergency care unit, which has 6 trolleys and a waiting room with 27 seats. They're open from 8:30 till 5 for ambulatory work, but they do stay open until 10 to support the triage of the medical intake. The unit is staffed by 4 registered nurses and 1 HCA, 1 consultant and 2 junior doctors, or occasionally 1 junior doctor and advanced nurse prac. Patients are generally investigated the same day, or if they arrive too late in the day to arrange a scan, they're given stat doses of anticoagulant and booked in to be seen the following day. Once they arrive in AQ, they're seen by a junior doctor or an advanced nurse practitioner who takes a full history. They're then guided by a specific pro forma designed to identify risks and direct whether further investigations are necessary. Following this initial assessment, scans are arranged, any necessary investigations, including Dopplers and CTPA. We're very lucky that the radiology department is adjacent to the unit and are able to respond quickly to investigation requests. Most are undertaken promptly, but worst within a few hours. Once the results of the relevant investigations are available, the patient's reviewed by the consultant of the day. If the patient is found to have a clot, the results are explained to the patient and a treatment plan is agreed. Depending on the clinical scenario, including other symptoms or warning signs, further investigations may be required, such as a PSA in a male, for example. In most cases, our first-line management for either DVT or PE is to start apixaban, 10 milligrams twice a day for 7 days, followed by 5 milligrams twice daily. However, rivaroxaban, low molecular weight heparin, or warfarin in exceptional circumstances are available should the clinical need require. We do not routinely use either edoxaban or dabigatran in the acute management of DVT due to the requirement of the lead-in for low molecular weight heparin. Once the plan is agreed, the patient is seen by a nurse who goes through the medication following a comprehensive checklist to ensure the patient is fully aware of how to take the medication, what side effects to watch out for, and what to do if they experience any unexplained bleeding or bruising, and how to obtain further advice if needed. Training is provided by the pharmacy anticoagulation team for all new nursing staff and updates periodically to ensure all staff are aware of the importance of this step and what needs to be covered. Staff are also provided with written educational material to give the patients to reinforce the key messages. At this point, a specially designed VTE risk assessment and prescription form is completed, detailing the treatment plan. This is also used as a prescription to obtain the first 7 weeks supply from the hospital pharmacy, ensuring the patient doesn't run out before they're able to obtain further supplies from their GP. This form also triggers a referral to the pharmacy anticoagulation service. Before dispensing, the prescription is checked against the patient's other medication and characteristics such as age, renal function, and weight to ensure the drug choice is appropriate and the dose is correct. Some examples of issues picked up at this stage are co-prescription with other medication which may lower the effect of the DOAC. A good example being primidone, used for essential tremor. The interaction is not listed in the BNF. However, its active metabolite, phenobarbital, has the potential to reduce the effect of the DOAC and may necessitate an alternative approach. On receipt of the risk assessment and prescription form, the patient's booked in with the pharmacy anticoagulation service for a routine phone call 7 to 10 days after starting treatment. The purpose of this call is to check the patient isn't experiencing any issues with their anticoagulant, but also to check their understanding and compliance with the treatment. It also gives the patient or carer an opportunity to ask any questions they may have or raise any concerns. You'd be surprised by the frequency and range of issues and queries we experience at this point in the pathway. A recent example involved an 84-year-old gentleman that was diagnosed with and treated for an acute PE. He was started on apixaban 10 milligrams twice a day, with instruction to reduce the dose to 5 milligrams twice a day after 7 days. He was also started on 2 lots of antibiotics for a concurrent chest infection. He was fully counselled on his medication prior to leaving hospital. When he was contacted by our service 7 days later, he reported black stools and coughing up small amounts of blood. On further questioning, we identified he'd actually been taking apixaban 3 tablets 3 times a day for the last 7 days. He knew he was to reduce his dose that day, but he was actually going to drop it to 1 3 times a day. He hadn't actually taken any of his antibiotics. He had, however, remembered that he needed to report any unexplained bleeding or bruising, so he'd made an appointment to see his GP that afternoon. During this phone call, we also ensure the patient has taken the risk assessment and prescription form along to their GP practice to ensure primary care have all the necessary information to continue to supply the DOAC safely. In our area, we also have an enhanced service, which provides a resource to enable GPs or their teams to follow up patients on DOACs appropriately and ensure continued prescribing is safe. The pharmacy anticoagulation team are often the point of contact for the primary care teams if they experience any queries. Again, providing another layer of safety net for patients on high-risk medication. The final step in the pathway is a review by the initiating consultant after 3 to 6 months, depending on indication. It's at this point that the anticoagulation treatment is reviewed and a shared decision is made about whether it should be stopped or continued. To add some context to service, here are some activity figures. So for 6 months last year, we had a total of just over 1,700 patients attending AQ. The total presenting with query VTE was 42%, so a big workload, as has already been mentioned. However, the total with the confirmed VTE was a lot less, only 6%. So just a summary, to recap the benefits of the multidisciplinary approach to the ambulatory service. There's ease of access for the patients, they've got prompt investigations, there's a real emphasis on shared decision making and a clear plan in place at the point of diagnosis. There's a big emphasis on patient education. Prescription screening has been very important, the examples we've given you to show, and the follow-up phone call a week or so after starting the treatment is proved to be invaluable. And also the benefits of having a treatment review by the initiating consultant at 3 or 6 months. So thank you for listening, and if anybody's got any questions, please let me know.
Thank you very much, Jan. Jan just sent a message. Sorry, Sue, thank you very much. That was lovely. It's really good to see that the pathway you've got in place is working so well. And I think, well, some people say pathways are too rigid and, you know, you shouldn't have such rigidity. Personally, I think pathway is a very good idea, because if you've got people coming in work, you know, the clinical staff who are not familiar with the system and the method of work that you're trying to achieve, then at least if there's a pathway in place, you know that the patients are going to get the same standard of care, regardless of who is providing that care. So I think that's excellent. And I believe that it was this pathway and this work that won you the award at the Anticoagulation Awards this last year. Is that correct?
Yes, it is. Yeah. So yes, the team were acknowledged for their efforts, and for that we were very grateful. But yeah, I think it is something that we're proud of, and I think the multidisciplinary approach, including the nursing staff and the doctors on the pharmacy, yeah, is a successful model. So yeah. Yeah,
no, that's great. And I could just take this opportunity, and I'm sure Joe won't mind if I have give a little plug for the Anticoagulation Awards, which are held annually. You can find out about them on Thrombosis UK's webpage, and any work that people are undertaking involving anticoagulation, thromboprophylaxis, have a look if you can fit in with one of the categories, and I'm putting a paper for the awards. It's a lovely day, and a great opportunity to share the really good work that's going on all around the United Kingdom. So yeah, so thanks for that. So I'll just see if there's any questions here. So Jan has said, thanks, Sue. And honestly, would not be that efficient without help from pharmacy. Is Jan a pharmacist, do we think? Yeah, absolutely true. And I think really it's collaborative working, because if you've got excellent pharmacy team, excellent nursing staff, excellent clinicians, even down to your administrative staff, if everybody works together and supports each other, provides you with a very good sort of pathway and experience for patients. What else have we got? What's this one? Oh no, Joe's one of the consultants who works and said, oh, okay.
Jan's our consultant lead, and we do work very closely, and it's and that we also have sort of regular sort of MDT meetings about difficult patients, and again, that model's worked out quite well as well. So yeah, I think appreciate Jan's comments there, but we couldn't do it without them. So thank you.
No, that's great. Yes, nice to meet you, Jan. So has anybody else got any questions for Sue, because we are running slightly ahead of time now. If anybody has any questions, if not, then we'll move on to our final presentation for this Welsh Showcase session. So I'm pleased to welcome Christine Welburn, who's thromboprophylaxis nurse specialist from Obstetrics Gynaecology in Beth Cadwaladr Health Board in North Wales. Christine has recently taken a position with Welsh Risk Pool. Christine also sits on the All Wales HAT steering group, and this really good, because it means that we have direct links, obviously other members of the All Wales HAT steering group, but specifically with Christine's role, she's actually more involved with Welsh Risk Pool. And so, you know, it's a good link for us all to have. Now, Christine's going to share with us a local piece of work. And again, this won an award at the Anticoagulation Awards last year. And this work was used to improve VTE risk assessment, taking an APPLE approach, that's APPLE approach to VTE prevention in the hospital setting. So over to you, Christine. Thank you very much.
Thanks, Andrea. So I'm Christine. I'm the thromboprophylaxis nurse from Glenclwyd Hospital, which is one of the hospitals that form BCUHB in North Wales. So I'm going to go through our APPLE approach. If my slides move.
Oh.
Oh, there we go. So BCU is the largest health board in Wales. We serve a population of over 700,000. And because we cover such a large area, BCU is split into 3 areas, which is Central, East and West. And the hospital I'm based in is based in Central North Wales. So I thought I'd go through a timeline of the events that led up to creating our APPLE approach. So 2017, our hospital had high rate of potentially preventable HATs. We had no thromboprophylaxis nurse in post. We had a lack of feedback of lessons learned and a lack of VTE education and MDT approach. In August of 2017, they employed a full-time thromboprophylaxis nurse, which was myself, and then we commenced the thromboprophylaxis walkarounds in September of 2017. And this enabled us to give real-time feedback and guidance and education to the clinicians. And then from that point, we started doing regular HAT and VTE training given to all doctors on the inductions. VTE training offered on a monthly basis to doctors, nurses, pharmacists and physios. We also completed regular audits and quality improvement projects, including updating our theatre safety checklist, which now has thromboprophylaxis on each section. And we also do training and lessons learned given to all departments, clinical governance and ground round meetings, as well as reporting to our governance meetings. And we've also worked collaboratively alongside the All Wales HAT steering group, 1,000 Lives from Bursis UK, and now the Welsh Risk Pool. So 2020, our HAT service got suspended due to the COVID-19 pandemic, and our HAT service didn't resume again until the middle of 2021. Now, at the same time as our HAT service coming back into play, we also had the Welsh Risk Pool, who carried out a patient record review and produced a report which had the 5 recommendations in it, which Andrea went through earlier on. And also at the same time, we also have to apply for revalidation of our national exemplar site status. So we had a lot going on when our HAT service was resumed. So because of this, we created the Apple approach, and this was to improve our practice, because during the COVID pandemic, our practice did slip and our preventable HATs did increase. So we wanted to improve our practice, and we also needed to achieve our Welsh Risk Pool recommendations and also achieve our exemplar centre revalidation. So we created the Apple approach, and this was implemented across BCU, so all 3 sites, with good results from late 21 to 22. And our Apple approach did win a national award which was presented on Obstetrics UK last year in November 2023. And then this year in 2024, we've amended our approach slightly, and it's gone from Apple to Apples now, and this is due to the lessons learned from our root cause analysis. So the creation of our Apple became because of the results showed that during the COVID-19 pandemic, without the education and support from the HAT team, compliance in completing the VTE risk assessment tool decreased and our potentially preventable HATs increased. This changed compliance indicated that, coupled with the pressures of the COVID-19 pandemic, whilst our thromboprophylaxis walk-around did improve our compliance and sustain our results at the targeted level, it was still relying on the HAT team to drive it. Therefore, we needed a new approach, which was our Apple approach. In order, we created the Apple and incorporated that into our thromboprophylaxis walk-around in order for all our clinicians to then take ownership of the work. So the need for Apple for Betsy was because we needed all our clinicians to take ownership for the VTE prevention practice. We needed to create a memorable aid for best practice in VTE prevention, and we needed a way of implementing our lessons learned into practice. And we also needed to create a process where it could be spreadable to our other hospitals, because we wanted to standardise all our practice, particularly in VTE prevention, across all of North Wales. So it needed to be something that could be replicated in our other sites. Our work needed to achieve the Welsh Risk Pool's recommendation, but we also need to achieve the VTE exemplar site criteria as well. So there was a lot of things that we needed from one approach. So this is what we came up with. So this is our Apple, which is our acronym for our MDT approach. And it stands for A is for the assessment. So that's our VTE risk assessment. So we're asking all the doctors and AMPs to complete the VTE risk assessment on admission when they're clerking the patient in. The first P is for peer review. So we're asking all our consultants to check that the risk assessment has been completed and the prescription is completed and correct, or when they do the post-take ward round. Second P is for pharmacy check. So this is where we're asking all the pharmacists to check whether the risk assessment's been completed and the prescription is correct when they're doing their checks on the ward, and they're very good at picking up any drug mistakes, particularly if it's to do with renal dosing of thromboprophylaxis. L is for leaflet for patient. So here we're giving the IDO VTE leaflet information leaflets to patients on admission, and this is because it's bilingual, but now from British UK has done a Welsh version of their leaflet. We're also allowed to include that as a secondary information leaflet as well. And E is for education. So this is to educate both staff and patients on thromboprophylaxis and also on the signs and symptoms of VTE as well. So the images on the bottom, the first one is our VTE prophylaxis box, which Andrea mentioned in her presentation. This is because currently we're still paper-based for our medication chart. The second image is our Apple audit sheet that we do on our walk around to assess the compliance to Apple and best practice to thromboprophylaxis. And then the last one is our VTE leaflet given sticker, which the nurses, once they're given the leaflet and explained it to the patient, they will put on the drug card, just so it's documented that the patient has had written information, because this often gets missed in the documentation. So this is the effects on our potentially preventable HATs in our health board, in our hospital. So in 2017, there was no HAT service and no thromboprophylaxis nurse, and we had 22 potentially preventable HATs. In 2018, when there was a HAT service and the thromboprophylaxis in post, and also when we did our thromboprophylaxis walk around, we decreased that to 4 potentially preventable HATs. 2019, we had 0 preventable HATs, and we actually had no preventable HATs for about 18 months. And then 2020, when the COVID-19 pandemic came and our service got stopped, during that year, we went from 0 up to 9 potentially preventable HATs. And then in 2021, when the HAT service was resumed, it came down to 7. And then from 2021 onwards was when we implemented our Apple approach. So 2022, we had 3 preventable HATs. And then 2023, we haven't completed the data. We've got a couple of months left to finish, but so far we've got 1 potentially preventable HAT. And this was due to a missed dose. So there's 1 blank box on the drug card that hasn't been signed or coded. So in Wales, we count 1 missed dose as potentially preventable HAT. So because of this, we've amended our approach a little bit from Apple to Apples. So Apple is completely the same, and then we've added an S on the end for signed for. So we're just doing some more education with the nurses regarding making sure that they sign or code the medication chart every day, particularly if we have agency nurses coming in, to make sure before they go off shifts that they've checked the drug cards and that there's no blank boxes. So to evaluate our apples, there's a lot of pros to it, more than there is cons. So our pros is our lessons learned did identify 4 opportunities to ensure that VTE risk assessment tool was completed and that the appropriate thromboprophylaxis was prescribed. And by having an MDT approach, it increases the likelihood of best practice. The results so far are showing a positive impact on our practice. Incorporates VTE information given to the patients, and it has encouraged our patients' participation in their care and patients' compliance with the thromboprophylaxis, especially if they have extended thromboprophylaxis. Our MDT approach prevents dependence on one person and service, which happened as a result of the COVID pandemic, highlighted that it was our HAT team driving it, but now hopefully it's get driven by all our clinicians. It doesn't cost any additional money to implement. It can be implemented in any health board or trust, as the Apple's acronym reminds clinicians of the best practice, and it's flexible in the way you want to implement it. The cons is that it does rely on senior clinicians and hospital management team to buy into the project, and each health board will have to decide on how best to implement it in their practice. We already had our thromboprophylaxis walk around set up, so it was easy for us to assess compliance and drive it that way. Other health boards might want to do it a different way. So our take-home message is that the improvement work in BCU has shown that it is beneficial for having a dedicated thromboprophylaxis nurse and a HAT team. Achieving best practice and patient safety really needs to be MDT approach. Sharing experiences and improvement projects can be replicated across sites to improve patient safety, as we've done across BCU sites. And also that our Apples approach can be implemented in your practice. We're hoping that this is going to spread across the rest of Wales, and we've also had interest from a couple of trusts from England as well to implement it there. So hopefully everybody can see the benefit of doing the MDT approach. And that's it. That's my email in case anybody wants any more information on the Apple approach, or want a copy of our audit sheets. Thank you.
Thank you, Christine. Brilliant. Really well done. It's excellent to see the work that's going on, and I'm really happy that everybody who's presented today has has shown the great work that's going on all over Wales. And I think one message that you've really highlighted, the same as Sue did, was this multidisciplinary approach. Because if we try and do things either in silos or, you know, individuals, it's just it's impossible. But once you start to expand and include people and make them feel valued and show them the benefits of their work, and looking at your graph and looking at, you know, the graphs that we've produced in other health boards in Wales, where you can show the drop in HATs and the increase in risk assessment, I think it really encourages people to want to, you know, participate and get involved, because we can make a difference, and we're proving that over and over again. So I think you're going to have to bring your apples along to our summer meeting, where then the All Wales HAT steering group meets again to look at sharing practice. Holly Arter said, brilliant, Christine, thank you. And I think, yeah, this standard approach that we want to try and implement across Wales, where we're sharing best practice and bringing in, I mean, ideally, if every site was an exemplar site, because then that demonstrates the standard approach. And certainly if you have exemplar status, it does help you to get that collaborative working, because you've already got the collaboration with everybody to be recognised as an exemplar site. So I think two things we need to do. One is to look at your apples when we meet again, and also to start looking at the exemplar status and see where we can go with that. And that's the same for all health boards and trusts, regardless of whether you're in England, Scotland, Ireland or Wales. If you've not looked at getting exemplar status, have a look at it, because it really is beneficial. It's hard work. It's very rewarding, and at the end of the day, the benefits of it greatly outweigh the negatives and the potential for harm to people. So thank you very much. I'm just looking to see if there's any more questions. Lots of thanks, but no other questions. So if anybody has any questions, we'd like to send them through now. Otherwise, thank you very much, Christine, and I shall speak to you again soon. Well, that comes to the end of the All Wales showcase, and I hope everybody's enjoyed seeing some of the work that's happening in Wales. I think that there's an awful lot of good work going on in Wales. We share what we're doing, we support each other, and hopefully you've seen a little today where that collaborative working and sharing is helping us to move along in the right direction. We're in the brink in Wales of going on to electronic prescribing. Lots of changes coming in at the moment, which hopefully will improve things for the better, and we're always moving forward. I'd like to thank Joe for helping to set this up and supporting us through this session. And I'd like to thank everybody that's from Both UK who've been involved with this. And I'd like to thank everybody who's taken the time to come in and listen to us today. And hopefully you'll tune in now for the rest of the conference and listen to a lot of really good work that's going on all around the country. So thank you very much.